Good morning. Thank you for joining us here. My name is Nalan Yurtsever, and I'm a blood banker by training. So today I will be talking to you about some transfusion medicine, specific considerations in sickle cell disease, and also the more like the blood bank aspect of it. So this is just the outline of my talk, and we will talk about the types of transfusion first. As Dr. Holbert already mentioned, if you are going to have a transfusion, it probably means that your doctor has already made the assessment and has decided that the benefits of a transfusion are outweighing the risks. So there are different ways for somebody to get transfused. The first one is something we call simple transfusion. It's just you getting a unit of red cell collected from a healthy donor and given through a routine IV access. The other one is called exchange transfusion, which is a more specialized type of treatment. It requires a skilled personnel and an apheresis machine, and likely 2 IV lines or a port. This is when we collect your blood through one line, and the instrument processes it and removes your sickle cells into a discard bag, and then the instrument will also replace them with a healthy red cells from a donor, and then give them back to you. So just to visualize it, this is a simple transfusion. There's a unit of blood hanging, patient is getting it through the IV line. This is, on the other hand, is exchange transfusion. We see this child here connected to this apheresis instrument. We do this up in our clinic with, again, a specialized nurse and a doctor with it. You see that there are 2 lines here. One is taking the blood into the instrument, and then this is the discard bag where the instrument separates your sickle cells and puts them into this discard bag, and then a fresh unit of red cell is hanging by her, so it goes back into the patient. So this is not just giving you the donor red cells, but it's also taking out some of your sickle cells, so the efficiency is greater with this one. But of course, it is a more complicated type of procedure. What are some of the indications? I mean, we have been talking about stroke, since the morning. Stroke is one of the biggest indications. Almost always requires transfusion. Acute chest syndrome. If this is severe, there's pain in the chest, you might get a transfusion for this one. If you have failure in multiple organ systems, such as liver or kidney, again, you might get a transfusion. If you are having pain in the splenic area, you might also get a transfusion for that. There are also some other low acuity transfusion scenarios. For example, if you are going to have a surgery, your doctor might decide to give you a transfusion to optimize oxygenation. For some patients, again, they might get transfusion during the pregnancy. It helps to lower the sickle cell volume, so it might help slow down the progression of other complications, such as preeclampsia. You may have heard about this. And in some cases, you might also get a transfusion to help with pain crisis. So now we are going to go into a little more blood bank perspective, the blood bank angle of it. Let's talk about antigen and antibody problem. So we call it antigen, but you can remember it as like a tag on the red cells. Typically, when a patient with sickle cell disease presents to our facility for the first time, we will not just do the ABO and the type and screen, we will also fully type their red cells and understand which combinations they have. So you know about type and screen. Whenever you are having a transfusion, they will draw blood, and typing basically means we look at your ABO type, are you A positive or negative, etc. But for sickle cell patients, if it is first time here, we also do an extended typing to understand which types you have. It looks something like this. Those tags, the antigens, we give them different letters. There's like at least 50 of them. We don't even know all of them, but we care about the more common ones. Like you see here, CE, V, Cal, here MNS, these are called Duffy, JKA, like the KIT system. So it just shows that this is typing from a patient. For example, this patient is lacking the little c, but has a big C here. So this is how we know what they have. And then we use this to predict the antibody. So what is an antibody? Let's imagine this is the healthy donor red cell. This is in the red cell bag that you are going to get, and this is your sickle patient red cells. You see there are tags on them. I put some here. This, it doesn't have to have this combination. It just means that the donor and the sickle cell patient are different people, so they will have different tags. For example, the healthy donor here has a big C tag, but the sickle cell patient doesn't have it. So what happens, maybe not the first time, but eventually when they, the more they get transfused with this donor's blood, eventually sickle cell patient's immune system will say, hey, wait a second, there's something foreign here. I don't recognize this big C, so maybe I should fight against it, because anything that's foreign in the body, I should fight against. So then they start, the sickle cell patient will start making antibodies against this big C. And then eventually, if you still keep transfusing these red cells with big C on it, the immune system will destroy the red cells. So we call it hemolysis. So you will see hemolysis. That's why we do type N screen every time. So we know when a big C, anti-big C is there, we do not give you big C blood anymore. So it is, at some point, it is somewhat inevitable, because if you get frequently transfused, eventually you might make an antibody or two. If you lack something, the donor has it, then you might make an antibody against it. Once you make the antibody, we have to make sure we are giving you blood that's negative for that tag. As you can imagine, the more antibodies someone makes, the more matching we have to do. Like if you have this, so if you made these antibodies and then this was your blood type already, now we have to give you blood that's negative for O, D, big C, Cal, S, etc. So you get the point. So the more antibodies, the more matching, the decreased possibility of finding blood. So our entire goal in blood banking and asking you type on screen every time is to make sure that we are giving you blood as matched as possible. The other problem we have with antibodies is that they disappear. We call it evanescence. So let's say here you made the antibody for some tag, and then here you're in Boston at Dr. Halbert's hospital, and then they detect that you have an anti-big C, so they know it. But then you are visiting a friend here in New Haven, and you come to Yale, and then you have a pain crisis, you go to the hospital now. Yale and Boston Children's may not be connected, I don't know if they are. But here we do the blood bank testing and we do not see the antibody. It is there, but it is so low that we cannot detect it. So without knowing, we might give you a blood that's positive for big C, and then the antibody comes up right back, because the immune system will still remember it. We cannot detect it, but the immune system will remember it and will destroy those red cells. So it is really important for you to keep us informed in that, or at least let us know that you had a testing done over there, so we kind of communicate. This is part of the antibody problem. Just like the example I mentioned, it happens that the sickle cell patients visit different hospitals for different reasons. Either they get a consultation or they are visiting and have an issue, so they have to go to the hospital. You see how many hospitals a sickle cell patient visited. This was a study done. That complicates things because our blood bank records do not connect. So again, the advice is either please somehow communicate your results with us, know your antibody history, the latest one, or at least tell us that, hey, I got a transfusion there, or I had a testing done over here. We can give them a call and figure out what their latest testing was. This is really, really helpful in protecting you and making sure that we are giving the correct unit to you. So it comes to this, when we are issuing a unit of blood, so when we are selecting we have this fridge full of red cells, this is blood bank. So when we are selecting a red cell for you, we make sure, this is for anybody who gets a transfusion, not just sickle cells, we make sure that it is matched for ABO and the D antigen. But for sickle cell, they make a lot of antibodies against these ones, like the big C, the big Cal, big E, etc. So we make sure that we are also matching for this. So we call it extended matching. We are making sure that each unit of red cell you get is matched for these. Now you can say, how about these ones? You are not matching for these. We can't. Otherwise, it would just be impossible to give you blood. So for these, we only match when you make an antibody. But we always match for these ones. So whenever you are getting a red cell unit, it is matched for these, match for the antibodies that you have. And of course, it has to be sickle cell negative, because that's the whole point of giving you a red cell. This is my last topic that I want to discuss. There's something called hyperhemolysis. If there's some antibody that was there, disappeared, and then the patient gets a unit that has that tag, that has that antibody, and the unit has that tag on it, As I mentioned, the red cells will be destroyed. There will be hemolysis. But there's something, there's a phenomenon in sickle cell patients called hyperhemolysis, because their immune system sometimes, because maybe it is hyperactive, we don't exactly know why, but when they start destroying the red cells from that donor, they accidentally start destroying their own red cells too. So we call it a bystander effect. So they actually end up with a lower hemoglobin than they started, because they also ended up destroying their own red cells. It is critical to note about this, because for now at least the only scenario is to avoid transfusions unless these people are critically anemic. So we try to keep a record of these people in the blood bank and try to communicate, and either we or the hematologist will remind each other to make sure we are not transfusing unless absolutely necessary. So this is just summary of my slides. In blood banking, it might get a little more complicated, but I think this is like the gist of it. Red cell transfusion or red cell exchange is important in preventing complications. We type you whenever you come in for the first time. We will type you. If you go to Boston Children's for the first time, they will type you as well. Most institutions do that. And then we will try to match for those ones. And then for the antibodies that you have, it is essential for you to share with us the antibody records that you have, or any blood bank testing records that you have. And I can take the questions later. Thank you.